welcome and introduce you to our lovely panelists who I'm so honored to be on this stage with. First, to my right is Keaweʻaimoku Kaholokula, who is a tenured professor and chair of Native Hawaiian Health at the John A. Burns School of Medicine at the University of Hawaiʻi at Manoa, and a licensed clinical psychologist. As a Native Hawaiian, he is passionate about improving the health of Native Hawaiians and Pacific Islanders, and has made a lifelong commitment to improving their social and cultural determinants of health. And next to him is Marie Kainoa Fialkowski Revilla, who's a wife and mother of 4. She is a registered dietitian, nutritionist, and an indigenous breastfeeding counselor, and is the first and only tenured Kanaka Oʻiwi faculty member in the Department of Human Nutrition, Food, and Animal Sciences at the University of Hawaiʻi at Manoa. I'm so delighted to be up here, and just wanted to give you first a moment to introduce anything else that you want to introduce to the audience, as well as including your research interests.
Aloha mai kākou. Mahalo for allowing me to be with you all this evening. Mahalo, Anita, for the beautiful introduction. As she mentioned, I'm at the University of Hawaiʻi at Manoa. I'm super honored and stoked to be here because Keawe has been my mentor and I've looked up to him my entire career. So the fact that I'm sitting next to him is like, oh my God, wow, so cool. So I spend a lot of my time in the classroom. I teach within our dietetics nutrition program, and I'm really striving to make our classrooms more place-based, integrate our culture, integrate all of those awesome things that make our community amazing, so that we can prepare future dietitians, future people who work in nutrition to be able to navigate our communities and do it in a pono way. So I spend a lot of my time doing that. And as Anita mentioned, I'm a mother of 4. I love having babies. Mahalo to my sister-in-law in the corner who has my baby Keaweʻaimoku. She's on call tonight. So I spend a lot of my other time in infant nutrition. I love that whole realm, that life stage, and indigenous nutrition. So it's a little bit about me. Mahalo.
Velina me ke ola ia kākou, mahalo. Mahalo to Waiwai Collective, Keone, Mahinama, mahalo Anita, and mahalo to all the supporters, organizers, co-sponsors. And mahalo for that nice, thank you, very kind words. I'm a big fan of Kainoa's work, and she may actually be getting more research happening in the area of indigenous nutrition. A little bit about me, well, for the last almost 20 years now, been an active researcher addressing the health inequities among Native Hawaiian Pacific Islanders, mainly designing interventions, culturally based, community-based interventions that addresses issues around cardiometabolic health, so diabetes, cardiovascular disease, and the risk factors. And do it with co-producing this research and co-conducting it with Native Hawaiian Pacific Islander communities using community-based participatory research. Another line of research that I do is actually looking at the effects of racism on the health of Native Hawaiians and Pacific Islanders, and hopefully I'll get to share some of that here today, as well as some advocacy work on the national level.
Thank you. Oh, yes, that's working. First, I wanted to, talk about right now. We're still in a pandemic, and during this pandemic, we have really seen the Hawaii's health disparities really thrown into sharp relief. And part of what drove the high COVID rates in our communities was the existence of many pre-existing health problems. I was wondering if you could please tell us more about the landscape for health disparities affecting Pacific communities even prior for the pandemic. What sort of health challenges do our communities face, and how does that compare with the average Hawaii resident?
Yeah, the COVID-19 pandemic really, exposed the cracks and the problems with our political, economic, even our healthcare systems, right? So we had all these pre-existing inequities, long-standing inequities that we were not able to resolve or even get a handle on. And so when COVID came, it just exacerbated everything, right? So those who already had all these inequities were more likely to have inequities related to COVID, right? But prior to the pandemic, so when you look at Native Hawaiian Pacific Islanders, you're talking about food insecurity. a lot of the nutrition-related chronic diseases were most prevalent, right? Diabetes, heart disease, and all the risk factors, hypertension, obesity, much more higher among Native Hawaiian Pacific Islanders. You know, our life expectancy is an average of a whole decade shorter than other ethnic groups here. We also get disease, chronic disease, an average of 10 years younger as well. And these were all pre-existing. Unfortunately, during COVID, it just got worse. And actually, going forward, because of the mitigation efforts we had to do, because the healthcare system had to focus on the COVID issues and free up beds and to keep people from being out in public and so forth, unfortunately, it may have led to more chronic disease. So those who already had chronic disease couldn't manage it well. And not to mention the food insecurity that came about because of the mitigation efforts that we needed to do, the loss of income, jobs, and so forth. But we're also probably going to see, and there's some data now coming out, showing that there's an increase now in incidence of chronic diseases. And again, most affected are Native Hawaiian Pacific Islanders. And I don't want to take too much, but during the COVID, of course, Native Hawaiian Pacific Islanders had the highest case rates of COVID and some of the highest hospitalizations and even deaths due to COVID. Early on in the pandemic, you know, it was really the Pacific Islanders that had the biggest burden and impact by COVID. And Native Hawaiians, compared to our population size in general, it wasn't as bad as Pacific Islanders and Filipinos. But after the vaccine came out, we saw a switch. Pacific Islander numbers went down, which is nice, but unfortunately Native Hawaiian numbers went up. And we're still struggling with that a bit. And again, it's post-vaccine that we saw that switch.
Yeah, just to add to that, when the pandemic, you know, a lot of the mitigation strategies that, you know, were useful for managing this infectious disease, you know, there's a little bit of a conflict with the way in which our communities, right? We're very social, multi-generational, you know, it's difficult. They want you to isolate kind of hard, right? So I think, you know, to add on to what Keawe was saying is, you know, these mitigation strategies that are shown to be able to work, you know, aren't necessarily conducive within our cultural landscape and the way in which we thrive, right? And having that social support and network and things like that.
In fact, I mean, yeah, our communities have larger families, larger households, live in denser communities, and we're more likely to be essential workers. Mm-hmm. So that also elevated their risk during COVID because they had to be out in certain jobs. And if you have multiple adults in a house or people working in the same household, also essential workers, it increases the chance of exposure, right? So all of this contributed, and these again are social, you know, food inequities or inequities across the board, economic deprivation, other issues really fed into all of that. And again, issues that we haven't really adequately addressed as a state.
That's a good segue into our next question about what are some of the root causes of these health inequities? Keawe, do you want to take that one first?
Well, that's a big question. It's everything, right? So income insecurity, housing insecurity, social insecurities, all of these insecurities, these social determinants of health upstream really is related to food insecurities. Because, you know, your food, and I want to say, you know, we often define food insecurity as simply having access to quality food or to a quantity, a certain number of food to feed us, to keep us healthy. But I want to add the quality of the food that we get. Because the issue here is, even though people are getting food to eat, the quality of the food really lends itself, high sodium, high fat, high sugary foods and so forth, that lends itself to obesity and other issues. Those are things we got to address. But it's all the larger issues that we've been challenged with. Issues around minimum wage, raising the minimum wage, livable wages for our people so they can actually get the food and the better, you know, food that they actually is healthy for them. Housing is still an issue. Now, because of COVID, housing prices went up, rents went up, everything went up. Incomes haven't matched the inflation that we're seeing, right? So it's all of these larger social issues that really is affecting us. And even aside from that, it's just the stress that has been placed upon everyone. Because we know that physiologically, stress increases cortisol, right? And because to prepare the body for the difficult situation, right? But because of that, you naturally crave high-fat, sugary, salty foods. So it's a combination of things that are kind of happening at a larger social and also at a physiological level.
And just to add to that, I guess I'll use one example. I said I work a lot in infant nutrition. So if we think about breastfeeding, breastfeeding is promoted as that's, the best way to feed our keiki, when they start off life. And, unfortunately within our community, our breastfeeding initiation rates, duration, they're lower than other communities, other groups. And I mean, when you look at, Keawe is talking about systemic things. I mean, systemically, we don't support families to breastfeed, right? And if many of our families are essential workers that gotta go to work, and if you don't have paid maternity leave, if you have to go back by week 10, you haven't even really settled into breastfeeding. So just from that one little example, it just shows that our system isn't set up to support families to be engaging in the healthiest things that we can within our families. So just with that one example.
Can I add to that example? Because you really touched on something. It's a big issue for me because a lot of the health promotion programs we develop and do, we're working with people, their families, helping them to make healthier choices. And I always say people want to do the right thing. They want to live healthy, but life pushes them in a particular direction. And what you highlighted was the fact that, most of our families are working more than one job, right, to make ends meet. And they have to go from job A to job B in the same day. It's hard to ask them to eat healthier because if you're going to get more fresh fruits and vegetables, you have to shop more often. You go to a supermarket around 5 o'clock, you're going to take an hour just to find parking sometimes, right? But these people are trying to feed their kids, feed themselves while they're going between jobs. And it's very difficult. So we ask people to do things for which the environment doesn't allow them to do it. And it's not a matter of priority for them often. It's just a matter of conditions. And when you have to pick between things, of course you're going to either get diabetes 20 years from now or 10 years from now or feed my kids today. We're pushed in that direction. I think that's and the structural issues are related to that.
And when we talk about these high rates of diabetes, a big question that we want to talk about today is what role does Hawaii's food system play in these high rates? And sort of where does food insecurity come in and sort of driving these high rates of disparities? Kainoa, I wanted to throw that one to you first.
Yeah, so I mean, unfortunately, and the COVID pandemic just highlighted, our food system is majority imported, right? So we are highly reliant on what comes into the state, not necessarily what we're growing here within our state. And so, that puts us in a very precarious position when we run into issues like what happened with COVID, where, we were under strain. And so with it being very import driven, that has, it places us at risk. The one thing that I did want to, mention that with our food systems, we're in an evolution, right? I guess, we have to take advantage of that we are in a state where we have to figure out, okay, how are we going to have a solution where we're not so much import based? And, obviously I'm not a tropical ag or food systems, that's not necessarily my area of expertise, but I have the honor of working with people within the College of Tropical Agriculture. So, I'll listen and try to absorb as much as I can from my colleagues. But, I did learn that our food systems has constantly been in evolution. When we think back to when the first Kanakas came to our island. And so if we just remember that we were constantly in evolution, and so we have to look at this as an evolution, and we have to figure out what's the steps. How do we kind of change that pendulum so that we're not so import-based, but yet try to switch it the other way. And so, we're evolving, I guess is what I want to make a point.
Yeah, we're definitely evolving in the food ecosystem is, so different now, right? We gave way to processed foods and so forth, much out of necessity in the earlier part of the last century and so forth. So it's totally changed. But when you think about it, the Homestead Act, actually, the Hawaiian Homes Commission Act that led to the Hawaiian homesteads, right, was a food security issue. It was a food sovereignty issue. It was to get Hawaiians back on their land for subsistence living, to grow kalo, to grow other things of importance to them, to our people, yeah. And that were healthy also for us. So when you think about that and talk about the change, the food ecosystem, we had a great food ecosystem. It changed and altered because of Western disruption. And then, we try to now through Western laws get back to something. But, it's changed, right? So most people on homesteads are not farming or doing what the original intent was, simply because now we're we end up in a labor economy and they had to go work. So definitely the food ecosystem is changing, the imports, the reliance on exports, imports coming in. But when we talk about, we'll talk about the food ecosystem. So we need more farmers, we need more local produce, right? We need all of this to not be reliant on these imports coming in. It's just not an access issue. Just having all that, it doesn't mean people are going to eat healthier. It doesn't mean they're going to be able to afford it. So we have to look at convenience. People want convenience, right? Again, they're working 2 jobs. Are they going to spend time, getting their vegetables, preparing them? It needs to be affordable for people. And that's usually the 2 things we think about. But the third thing is, it has to be a priority for them, right? That doesn't mean that it has to fit into the other things that they need to take care of. And until we can figure out all 3, access, ease of access, affordability, but how to limit these other stressors in people's lives and demands on them so that it can become a priority, then it's really going to be an effective system. And so the food ecosystem is just not the availability of food, it's how we use food and our ability to afford them as well.
And something I remember you mentioning when we were talking about this event was also the way in which food is very cultural. And so, of course, there's cultural food that has been part of our cultures for millennia, but there's also food that's become part of our culture maybe in the last few decades. Did you want to comment on that, Keawe?
Yeah, we had a prep meeting, and I was remembering when I was a real psychologist and I used to actually see people. So, I used to work on several different islands, Maui, this island, in Waimanalu, Waiʻanae and stuff. So I saw a lot of our Native Hawaiian Pacific Islander patients. And I'm a health psychologist, so I help people quit smoking, manage their hypertension to prevent, other diseases and so forth. And, especially at Kane, right? I would always talk about what they're eating. And we eventually get to Spam. Oh, we love Spam. And I said, well, okay, let's talk about the Spam. And this is what I got several times. Bruh, but I'm Hawaiian. In relationship to Spam, right? So, a good opportunity to process that. So how is Spam Hawaiian? Because as far as I know, I think it's made in the Midwest. It came out during World War II to feed the soldiers. But it's interesting because talk about how it's an identity now for them, part of the cultural identity. One, because it's a local identity too, right? Only McDonald's, in Hawaii and Guam get Portuguese sausage and Spam. So the food has become that, and it really got me thinking about how, at one time food was tied to kino lava, to our ancestors, right? It was part of our spirituality, it was a way to commune with our ancestors. And so we were careful in what we ate, even how we harvested and the food and so forth, and when we ate and what we ate at what time. We lost that. We lost that connection to a greater self or our spirituality. And I think that's something we ought to start getting back, so we can connect it to things that we really value. And then, we can, But Spam's not Hawaiian, so.
But it is tomorrow.
It's true.
To add to that, when Keawe mentions about how we have an identity, or we attribute identity to specific foods, I have some colleagues at the University of Guam, and they totally kind of shifted another perspective with Spam. They were telling me that, their love for Spam was that, well, if the soldiers who came and liberated them and they were fed Spam and it worked for them, then it's got to be good for us, And so, but it's, they attributed it, there was such meaning attributed to that because that was a very significant time within their history. And so, how do you change that, right? It's just, but these are very different. I mean, they're different communities, but we still have this same identity attributed to this one food item. I mean,
one thing that we Pacific Islanders all have in common, besides experiences with Western influence is also the war, and every community had different experiences during the war. Obviously, in Hawaii, it was Pearl Harbor and internment camps, but in Guam, for those who aren't familiar, they spent almost 3 years under a really brutal Japanese occupation, with forced labor. Comfort women, the kinds of things you might be familiar about if you've studied, what Japanese invasions were like in China. It was very similar in Guam. And there were about 20,000 Chamorros. There are many, infants passed from malnutrition. I mean, it was a very horrific time. And so when the Americans finally came, because that's the word my grandpa always used when he was describing what it was like, it was, that they really see that as Liberation Day. But it's interesting because I'm from Saipan. We were on the other side of the war. So there's, so many different experiences, but a lot of people ended up in some ways in some sort of camps after the battles and ended up eating Spam and corned beef for the first time. And those became part of all of our Pacific cultures. That's sort of the history behind that.
And then I just wanted to add one more thing. Keawe was mentioning about access and all of those factors about specific foods. If we want to encourage foods for people to eat. One of the things that within the infant space, we always, for a first complementary food, the first thing you want to give babies, if they're breastfeeding or if they're giving formula, is, traditionally we've said poi, right? And it was pretty amazing to see in some of the work that we've done that practice, parents want to do that, and we're still seeing that that's a commonly given food. But when we talk to the parents, they're like, that one little thing of poi, nobody touches that poi. That's for the baby, because that one little thing of poi costs $16 depending on where you're at. And so, just that one example speaks that people, communities, they want to be able to provide these healthy, nutritious foods, but, the problem is the access, the affordability, and things like that. I mean, if you're, $10 for an 8-ounce thing of poi, you're going to choose something else. Yeah.
Give the baby Spam.
Or possibly.
About systemic problems that our communities face, but we should also talk about systemic solutions. What are some big changes that can be made to improve the situation that we're in, and what are some efforts that are currently ongoing?
Well, I think, I'm an educator. I work at the university. And as I mentioned in my introduction, we need to train practitioners, right, that are able to deliver care in a way, and change the system, change our educational system, change the way in which we train students. That's just one component. I mean, it's a very complex situation that we're in that's going to require a lot of solutions, and then you're going to have that synergy. But just speaking as an academic, that's one place, the way in which we educate, how we prepare those practitioners, those providers, so that they can work to change the system, work the way in which we deliver care, how we educate, so that's just one component. I'll stop so I don't just keep going.
I'll jump on that.
Yeah.
So a workforce that reflects our communities across the board is needed. And I can say after 20 years in academics, I don't want to admit that, but 20 years after academics, what I've seen is as we increase the number of Native Hawaiian Pacific Islander health professionals and researchers, you see a corresponding improvement in access to care. Patients wanting to come to clinics, for example, because a Hawaiian is there. When I was working in Hana for a year, people actually said that. Well, I came because I heard a Hawaiian psychologist was here. They would have never come otherwise. Well, unfortunately, most of them are my family because of my dad's side, they're from Keaweʻaimoku, the Kaholokula, right? So, but it wasn't the Kaholokula that came to see me, but all on that side, mostly family. But the point is, we need a workforce that reacts. It's not just because one thing is people want to be comfortable with people like them. But we also know the cultural, community, social context to situate our medicine our psychological services or what have you. But even in academics, more researchers from our communities, you start to see more community-based, culturally informed strategies that are sustainable and wanted by our communities. So I've done, all different types of intervention studies over the years. The ones by far that people just want to stay in and want to continue have been those that are culturally grounded. So one would be our hula intervention, right? That we use to actually leverage hula as a cultural practice to address issues of hypertension and cardiovascular disease, where it's found to be very effective in a scientific study. So I'm a big supporter of community-based investments, private, public investments in our communities. If we're gonna look at, so you can do disease management, that's a Band-Aid. They already got the disease. We can help them better manage it. We can prevent getting worse and leading to other problems. Or we can start focusing too on prevention. And prevention's best done in the community, by community folks. And I think we need more investments in that area as part of the solution. And I'll stop there.
Yeah, no, and I think, unfortunately, sometimes we tend to be too deficit-driven versus asset-driven, and I think if we can kind of change our perspective to really focus on those assets. So one of the programs that I've been able to work with, the Children's Healthy Living Program, it's a USDA-funded, Dr. Rachel Novotny is the lead for that, but they were able to significantly reduce childhood obesity across the region through an asset-driven approach. So really focusing on the community, focusing on policy, focusing not just at the individual, because we understand that there's a lot of constraints at the individual level. So we need to look beyond the individual. What's their communities like? What's their built environment like? What's their policies like? And how can we take advantage of those things that are health promoting, right? And promote that and not necessarily focus on just what the deficit is. And so I think that can be another way in which to address the situation that we're in right now.
And that requires a shift in our paradigms. That requires us to move away from Western-based notions of health and well-being, or how we should address them, to a more holistic, indigenous approach to it, right? And other examples, just policy changes. Recently, good thing, right? Social Security is going to go up, right? Great for our kupuna to have more monies in their pocket. Unfortunately, we often see is in one area there's an improvement, it creates a problem in another area. So for example, we're already hearing from patients, they're worried now because they get SNAP benefits. And it's an income-based one of the requirements. And so it's just enough to put some people in the position where they're no longer qualified for SNAP, but they still need it. So and it's good that we're thinking about new laws and policies that help people and get people more monies into their pockets, and that's what we need more of that. But we also have to make sure that we think about the effects it's going to have in other areas, such as eligibility for medical care, for nutrition-related programs.
That reminds me of another policy change that occurred during the pandemic that is expected to help a lot of Pacific Islanders. So if you guys, I'm sure you both recall at the beginning of the pandemic, one of the challenges facing the Micronesian community was lack of access to Medicaid. And that was, something that had been a challenge, across the country since 1996 when they lost access to federal Medicaid. But in Hawaii, only since 2015, actually, because the state had extended access to MedQuest using state funds. But in 2015, the Ige administration ended that. And there was actually a UH study that came out that found that there was an increase in mortality in the Micronesian community between 2015 and 2018 after they lost access to Medicaid. Because for those who aren't familiar, Medicaid is a public health insurance program that's intended for people with very low incomes. So if you are like a caregiver or disabled or somebody who's not able to get insurance through work, that's who it's intended for. And so the community was trying to get insurance through Obamacare, but Obamacare wasn't really intended for people from those low incomes. And so it was a huge challenge. Anyways, during the pandemic, there was such an attention on the high death rates in the community that actually Medicaid access was restored. And so that's something that, is I think, been well received in the community. They've been pushing for that for a long time, but then comes with its own challenges of how do you make sure that people are aware of that they're able to implement it. And then even, Native Hawaiians have been on Medicaid, but they aren't necessarily able to find doctors when they need them. So there's a whole set of continuing challenges even as we make some progress. Sorry, did you want to jump in, Calvi, or I can keep asking and there are questions? Keep going.
One thing we can start doing too, and it's something we can quickly do, right? It doesn't require us to submit a bill and go through the leg session and wait 5 years before they agree to approve it. Well, I do think we got to support increasing minimum wage, livable wages. Our new governor coming in, is a big supporter of it. We got to keep him to that, push it, because the reason why in states that did that, increase minimum wage. So the issue is, we can't afford it. We can't afford not to do it. In states that increase minimum wage, they saw an increase in spending. So the more you make, the more you spend. So that means the state made more money. They got their money back, or at least the businesses may be paying it. But also studies show the more people make, the longer they live. And studies with low-income women show that just $1 increase. Just $1 increase in an hour increase in their wage substantially reduced their risk for adverse health outcomes. So there's all these benefits to doing this. So that's something we can support. The thing I wanted to say is how can our healthcare systems, and a lot of our healthcare systems are doing this. Queen's Health Systems, for example, is doing this, looking at social and cultural determinants of health and how to put that in place, which traditionally was a very, a Western-based biomedical perspective. And great things are happening, right? So you have navigators now at hospitals. Why are navigators important, or community health workers? They link folks when they come out of the hospital to the services they need to stay out of the hospital. So Native Hawaiian Pacific Islanders have the highest rehospitalization rates, meaning that within 30 days after coming out of the hospital, after being hospitalized for something, usually a chronic disease issue, they're more likely than any other group to go back in. And most of it is because of housing issues, family issues. They get back, they just don't have the means to get back on their feet. So having the navigators, and actually some work from Queens actually shows that it works. We reduce the rehospitalization rates when you have navigators navigate into these social services that is required of them, for them. The other thing we should think about more is food prescription programs, or what they call food pharmacies. In which doctors can actually prescribe, and there's a public-private investment in funding days. You get $30 or $40 coupon, or you can use that towards a farmer's market, a local market that is supporting this, right? And places that have done this have shown that actually chronic disease management improves, even in ethnic minority groups that they looked at. So even people with dire financial situations, it does make a difference. And I think we should do more of that. We need that.
Kainoa is coming and bringing another panelist to join us. And actually, this is a great segue to the next question I was going to ask you. Just when we think about solutions in your work with infants, when you get situated, I'd be curious if you have any potential solutions that you see on sort of a systemic level. But just to give you a few minutes so you don't feel rushed, I'll ask Keawe another question. The solutions that you're talking about are big and hard. I mean, I've covered the legislature and sat through the hearings about minimum wage and a whole session of lots of conversations, and then nothing happens, or sometimes it does, but it's not what people were pushing for. And so I think one thing that would be helpful is for people who are actually here in this room listening to this conversation, who really care about this issue, what is something that they can do right away to try to help make changes on these health disparities and make a difference on things that might feel, just very, very difficult to change.
So, in a more immediate way, it does take a while to get these bills and programs in place. I think we have to start as a family, as a community, really seriously talking and thinking about health promotion and what we can do to live healthier and better. On an individual family level, we see great success when families come together, family cohesion. And we know that families that are more cohesive actually do better. The kids do better in school. We gotta talk at the dinner table. Some of us don't have dinner tables, right? Because we live in apartments, it's a fold-up kind of tables, right? But we gotta find creative ways to have those discussions as a family, as a community, right? Because the more we talk to each other, the more we start to share and realize that we have to make these changes to help each other. We have to come back to traditional values of kupuna and caring for our elders. And caring for them means caring for ourselves. If we're not healthy, I see this too often where caregivers become ill before their time because they're so stressed, they're neglecting their health and well-being. So I think for all of us in the audience who are caregivers of others, you need to care for yourself too. You need to take time out, respite. You need to talk to your family members. And we know, usually you're the only person in your family doing them, right? You have a sibling, you get 5 other siblings, right? There's only gonna be one of you, yeah, we know. But you gotta talk to your families about this because so these are things we can do. We can start sitting down, having conversations. We can start thinking about how the spirituality of food and the connection we should have towards food. We have to seriously think about our identity. If we think eating Spam, and trust me, I was raised on Spam, canned salmon, corned beef, Vienna sausage, and occasionally I'm ono for that, and I'll get that. I try to reduce that because I start to think about the consequences. I also start to reconnect it to Hawaiian values. I think we gotta get to the core values. What do we value? We gotta start figuring out a way to help people manage the stressors. I know it's gonna take forever to get the minimum wage. It's gonna take forever to get to a better place in housing and so forth. But we gotta find ways to help people manage their stress. I mentioned earlier, stress increases cortisol. Cortisol makes you crave certain types of foods that are not good for you. So we gotta find better ways. Behavioral health, COVID-19, behavioral health concerns prior to COVID was a big deal. Now it's even more of a big deal. We're seeing an increase in depression, mental health issues, suicide, violence. These are mental health, behavioral health issues. It's not gonna stop. We have to address, but where do we get cuts? Where do we have least investments in behavioral health? We also have a workforce issue in behavioral health. And we're seeing that now. I can't get a patient in to see a psychologist, psychiatrist in a reasonable time. So these are all things we can start doing, is thinking about these as careers for your children, workforce. I know there's so much things we could talk about. I'll turn it over to you.
So this is Keaweʻaimoku. He's enjoying his early dinner, or third dinner, maybe you want to call it. So I guess, along that, one of the things that I think about, I learned from one of my other mentors, Auntie Kaiulani Odom over at KKV, the Hawaiʻi program. I know some of us in here have done the Hawaiʻi program. So one of the things that they emphasize is connections. It's palina, connections with yourself, with your past, your present, with your community, with your aina, and thinking about health from that perspective. And one of the things that I learned from them, I don't know, maybe it might explain why, I love babies so much, but, mana wahine, they shared with us that women, we carry the future within us. And so you want to eat well to support the next 7 generations because we carry that within us. And, too often, that's not the train of thought, right? We don't think about it in that way. But if we kind of changed our perspective, so we want to eat well for the next generation, so kind of just changing our paradigm, just following suit for what Keawe was saying, so we can attach those things to our food and how we view food, and we can still have that spirituality, still have that identity, but just kind of keep that within our context. I think is really powerful. That I wanted to add.
I also wanted to go back to the other question we were discussing about systemic solutions. So on a bigger level, more idealistic level, especially when it comes to your work with children and infants, what do you wish would change in order to kind of improve the health disparities that we're seeing, especially for women and children?
Paid maternity leave. We are the only developed country that does not have paid maternity leave. Yep. So speaking from myself, I am a state employee and I only have leave paid based on what sick leave I have available. Having a baby is not being sick. So right there is a systemic thing. And if we were to invest in our mothers who are having our babies so that they can stay home and breastfeed those babies, we would be way better. Because the evidence shows that if we're feeding our babies breast milk, your chances for obesity, for allergies, for asthma, for diabetes, and that's just from breastfeeding alone. And so we in this country do not make it easy for mothers to be mothers. So that's my thing.
I gotta add, it's a mental health issue too. By doing that, you the pilina.
Yes, yes.
The mother and child bonds better. The child's development over time is actually better.
Yes.
On many levels. So yeah, for many reasons, that should be done.
Well, thank you so much. You know, we're actually, I thought we would still be like chit-chatting way over time instead of coming in a little bit under time. We still have a few more minutes before we, you know, kind of break out into our discussions. And so I wanted to take the time to think about, you know, you've shared so much with us today, but what other takeaways would you want the audience to leave us with, or people who are joining us virtually? You know, when they think about health disparities affecting our community, what do you really wish people knew?
I guess just understanding that all these inequities is structural racism. It really is. Our systems have put us at certain groups at a disadvantage. It's by design at this point, right? Whether it's conscious or unconscious, it has worked out that way, where people of color are more likely to receive poorer education, have housing issues, even lower pay. I mean, women, lower pay than men, comparable CVs or resumes. Same with people of color compared to white majority. So we have to start looking and really thinking, you know, that it's a structural racism issue, and we have to start changing that. We have to, within our system, change practices, policies, so that there is, you know, I always say, so we always talk about equality. We gotta be fair, we gotta be equal. But it's not equal. We're not starting from the same starting point. In fact, some of us are pushed back. You know, you think of African Americans, they couldn't own property until recently. In some states, San Francisco area, there's still on the record some laws in which they are not prohibited in some communities, believe it or not, in this day and age. So they didn't acquire, you know, we get equity from the homes, we pass it on to our kids. There's generations of people that couldn't own homes and don't have wealth to transfer to the next generation. So for many of our people, they're starting from ground zero. They don't have mommy and daddy who have 2 homes and $1 million of equity. They got to raise that 20% themselves, down payment, and the security comes with that. We got to start changing that. We understand that, because I'm tired of hearing by, you know, my employers and others, but it's equal. They all have an equal chance. No, equity. We have to be inequitable to achieve equity, because we're inequitable. That led to the situation we're in. So we have to be inequitable. Let's swing it the other way. We have to fear. Now, affirmative action is being threatened by the Supreme Court, right? That's going to have a huge impact on many of our communities. We have to say we're going to get Native Hawaiians, Pacific Islanders into schools, into different professions at equal numbers as we represent in society. So if we're 25%, right? If we're 25% of the Hawaii population, we better well be 25% or more in every sector. So that's my finding.
I don't know, how do I come after that?
We
I agree, yes.
Well, I just wanted to say, that reminded me, I did actually have some statistics I was double checking before we met today. It's interesting because in Hawaii, I always remember at the beginning of the pandemic when we were having this conversation about, it was actually April 2020, and I was at a press conference with the Department of Health director at the time. And at the time, he said that he didn't expect to see racial disparities in Hawaii's pandemic. He said, except maybe for Native Hawaiians and Pacific Islanders. And his reasoning was that because he thinks that we're socioeconomically, a lot of us are on the same page, which, it's interesting because even though we're such a diverse community, there are huge disparities between different communities. And so I was looking, I think that Keawe was talking about life expectancy earlier. And so for some communities in Hawaii, the average life expectancy is as high as 87 years old. And then for Native Hawaiians, it's 76 years old. And for Native Hawaiian men, it's even younger at 73 years old. We're talking about food insecurity today. And, there was a study I was reading that was actually data from just before the pandemic. And it said that based on the behavioral risk factor surveillance system in Hawaii, 22% of the community reported some degree of food insecurity. For some communities, this was as low as 10%. For Native Hawaiians, it was 27%. And for other Pacific Islanders, it was 44%. So you see that even though there's so much diversity, that doesn't necessarily mean that there is, everyone's kind of starting from the same point. But I did want to throw it over to Kainoa. Was there anything that you would want to leave our audience with?
No, I think if we can just bring back our values and have that be a part of our everyday, aloha, right, malama, and those things, that goes a long way. There's a lot of systemic things, but just the way in which we carry ourselves and how we treat others, especially thinking about our practitioners and providers, sit down next to your patient, don't tower over your patient, things like that, just show aloha. I think those values will go a long way as well.
Well, thank you both very much for joining me today. And thank you so much to everybody who came and joined our conversation. If you'd like to stick around, we'll still be having, discussions among ourselves here. And so feel free to stay. And thank you for everybody who joined us online as well. I'd like to pass it back over to Alana.